For high blood pressure diabetes, if they have severe high blood pressure diabetes, it can affect their eyes, and they can have some abnormal growth of the blood vessel in their eyes. So what is going on here? When we have severe high blood pressure, it damages their eye. Severe diabetes damages the eye. And how do we know? So high blood pressure, retinopathy, we have AV nicking, retinal hemorrhages, and copper silver linings. For diabetes, it's going to be cotton wool spot, microaneurysm, and neovascularization. All those, you have to find out what it means. Neovascularization for diabetes is new blood vessels are forming. Okay, that's for diabetes. Microaneurysm, small blood vessels are busting open, or it's aneurysm, so it's not busting open, but it's kind of like poking out a little bit. Okay, if it's busting open, that is high blood pressure. Cotton wool spot, that's for diabetes. How do you remember this? So for diabetes, when we prick patient's finger, we wipe it off with cotton, right? So that is cotton wool spot. And M means microaneurysm. So remember first two, okay? Cotton is for diabetes, micro, which is for M, microaneurysm. For hypertension, AV nicking is very important. What is AV nicking? Artery and vein crossing over each other. Okay, so that is called AV nicking. For high cholesterol, if you see that person has super high cholesterol like LDL, which is bad cholesterol, greater than 190, make sure you start them on high intensity statins, which is Lipitor or Crestor. Then we have triglyceride that goes up. What do we do? So triglyceride, if it's like greater than 800, then we have to rule out something, which is acute pancreatitis. Very important exam question. Elevated triglyceride, what do you do? First, you rule out acute pancreatitis. Then, if it's good, then you put them on medicine. Okay. If it's less than 500 triglyceride, you don't do anything. Simply diabetes under control, lifestyle management, exercise, diet control, stuff like that. Anything goes above 500, then we do fenofibrate. That's the first choice of treatment. Niacin we can do, but it has a lot of side effects, so please don't select that in the exam. Fenofibrate is the first choice of treatment. Okay, greater than 800, then rule out acute pancreatitis. Heart murmur, you need to know location of the heart valve, and you need to know the mnemonics. Remember, then other thing you need to know is which murmur radiates. Okay, systolic radiates, diastolic don't. So location, and then check for the radiation. Are they radiating? Then you know it's systolic. Then you need to know the mnemonics. Okay. Then we have grades of the murmur. Here you need to know which grade of the murmur where you can feel the thrill without using your stethoscope. Grade 4. You can feel the thrill with the palm of your hand. Okay. That is grade 4. Heart failure, common one, right and left. Okay. So, and the very common one is the left one, left-sided heart failure, where the ejection fraction is weak or low. It's all about the lungs then after that, because heart and lung is connected. So left-sided heart failure affects the lungs right away. Everything is back in flow. They have crackles and cough and fluid in their lungs and wheezing, shortness of breath, all that. It's all about their lungs when they have left-sided heart failure. Right-sided heart failure, everything back flow again in the IVC, okay? Inferior vena cava, superior vena cava. Inferior vena cava, everything goes down. So that's why they have swelling going on, their belly swelling up, lower extremity swelling up, except jugular vein distension. That is right-sided heart failure. Remember, S1, S2 is normal heart sound, okay? But S3 is abnormal, and that goes for heart failure patient. S3 is normal for pregnant. If lady is pregnant, she automatically gonna have fluid overload, and that's what we want in pregnancy. Like, there is a baby, right? So there is a fluid. So yes, S3 present, it's okay in pregnancy. S3 present is not okay in heart failure. Arrhythmias, there are a bunch of, arrhythmias, but one arrhythmia is where we do blood thinners, which is atrial fibrillation, because it can cause person to have stroke, right? Sometimes we do Eliquis, Xarelto, Pradaxa, and those are expensive. Sometimes patient cannot afford. So for the exam, all those patients not gonna have money in the exam. Okay, remember, they'll be kind of broke in the exam. So yes, we always do cost-effective option. Think that they don't have insurance and they are broke. Okay, now how you gonna help them? And that's gonna be in the exam. So if they have AFib, then we don't have no choice. Put them on Coumadin, right? Coumadin goes with INR. We have to monitor the INR and stuff like that. So what do? First, we need to know the goal of INR for AFib and goal of INR for prosthetic valves, okay? Which is 2.5 to 3.5 for heart valves, which is mechanical valve, and for AFib, it's gonna be 2 to 3, okay? So for INR, if it's less than 5, what do? Simply hold the medicine, right? INR is less than 5, you skip a dose and recheck INR in 3 days. More than 5, which is 5 to 9, you do everything. You hold, right? You recheck INR in 3 days. If they are bleeding, okay, of course you decrease the Coumadin dose next time and all that. If they are bleeding, remember, then only give vitamin K. If they are not bleeding, don't worry about it. Okay? If it's 8, do everything. If they're bleeding, give vitamin K. Not bleeding, do everything. Don't give vitamin K. Patient with DVT, PE, they also need blood thinners. Real good question is how long? They're gonna need it for initially 6 months, and that's it. If they have it again, second time DVT or second time PE, definitely you're gonna give it for life. You are not gonna take this blood thinner off again. They're gonna have to take it forever, because if you take it off, then they will have DVT or PE again. And those are, if they have PE, that is life-threatening. Heart block. For heart block, second degree type 1 and type 2, very important. But how do you identify? Okay, so EKG interpretation, very important. If it's, getting worse, that PR interval. PR interval is worse, 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 getting worse, and QRS is dropping. So like progressive prolongation of PR interval and then QRS drop is type 1. Okay. And then fix, it's kind of more danger. If it's fixed PR interval, it's wider and it's fixed. That's what, it's more dangerous. So fix, and then QRS drop is type 2. Okay. Type 2 needs the pacemaker. Type 3 needs the pacemaker. Third degree AV block is needing the pacemaker. First degree AV block, it's okay, don't need pacemaker. Second degree type 1, don't need pacemaker. Type 2, if it's fix, QRS drop, need pacemaker. Okay. Then we